So today I wanted to talk a little bit about converting new-onset atrial fibrillation. How many of you do that? Okay, are you from some foreign country over there? No? Colorado? There you go. And over here, the Australians do it, yes? And the Canadians? Canadians, you do it?
No, Cape Cod.
Cape Cod? Yeah. Well, you're certainly in the minority of the hands that went up. And, but it seems to me that if you read the literature, this should be routine. This should be routine when you pick the right cases. Then that's really pretty important. And because, number one, people don't like being in atrial fibrillation, and their doctors don't like them being in atrial fibrillation. You incur a whole bunch of risks from these emboli, those kinds of things. Plus, it is very dysphoric for many, many people to have their ventricle bleeding in a random manner. Some people, they don't seem to know it. Other people, absolutely, it is very distressing. The other thing is that the quicker that you convert them, or try to convert them, the more likely you are to be successful. And the longer that they putz around into this, there is this idea of atrial stunnings that even after you convert them, the atria basically have not fully recovered and they're not working very well. And that's one of the theories between why people need to be a little anticoagulated for a period after the time that they have been cardioverted. So you want to limit that as well. And so the first couple of papers here probably should have been put at the end. It says, where can you do this? And the first paper is there from the Mayo Clinic and said, we do it in the emergency department. We exclude a lot of people. We exclude a lot of people. More than 48 hours. This will come up over and over and over. 48 hours is kind of the cutoff between when you can do this pretty much with impunity and when you start having to have these people anticoagulated prior to attempting a conversion. Now the literature on that, we'll go through the literature on that because everybody's concerned about it, but there is a strategy that basically says you can have your cake and eat it too, but 48 hours over and over, that is the number. They also basically excluded people who are hemodynamically unstable, as defined there, known intracardiac thrombi, congestive failure class 4, chest pain consistent with angina. They said class 4 angina. Never heard of that there's classes of angina. Well, I guess there are. And there's a list of other exclusionary criteria. And not that you're going to remember this list, but the fact of the matter is that if you're going to say to your hospital and to your cardiologist, let's start embracing this in our department, you'll want to certainly be aware of the list of people, of what has traditionally been excluded. So ultimately, when they found the people that they accepted into the program, 153 randomized to usual care or this ER protocol. They did rate control with calcium channel blocker or beta blocker. Everybody does that, no big deal. Cardioversion they were big on cardioversion with procedural sedation if you were still in atrial fibrillation for 6 hours. So they gave you 6 hours, but the fact of the matter is what they don't talk about here is, are you going to do anything in the meantime to see if you can precipitate this cardioversion chemically? They basically set a 6-hour time limit. You didn't convert, you got electric shock at the end of 6 hours. So you'd be looking, watching your watch, oh God, it's getting almost 6 hours here. Then they observed the people for 2 hours after converting them, and then they sent them on their way. Discharged with cardiology follow-up within 3 days. And one of the recurring themes here is that everybody who has atrial fibrillation needs to have an evaluation of their cardiac function. One of the ways that you can do that, first of all, is to do a echocardiogram. But that can be done in your department. I mean, that takes about 20 minutes to do an echocardiogram. You have them come down, it's not a big deal. Let them see what your ventricles look like, your septum looks like, the size of your atria, all of that kind of stuff, that's fine. But the next thing that they have to exclude is whether you have ischemic disease. And so whether you get some kind of test in the next couple of days determines to a certain extent your subsequent care. So there's 2 tests that need to be done. The echo and some tests for ischemia, whether it be some kind of thallium or those kinds of things, whatever is the test du jour is. These people said within 3 days. And then look at the outcomes. Mainly length of stay, 10 hours. 10 hours in the ER versus 25 hours when they admitted them to the hospital. We'll show you other papers, 4 hours. They're in and out quicker than they have a sprained ankle at our place, you know. Electrocardioversion, half the cases they cardioverted, and many of these papers say this is done by emergency physicians. Overall conversion rate, 85% versus 73% when they admitted them, reflecting that the sooner you get on this, the more likely you are to convert them. Follow-up at 6 months, recurrent atrial fibrillation, 10%. You wonder what the people were on thereafter, but that's not your affair, actually, whether they're going to stay on some drugs or whatever. 1 MI, and with regard to strokes and deaths and CHF, zero. And this is a study of 153 people separated randomly. Papers 2 to 6 all talk about where to do it as well, and they all encourage you basically to do it in the emergency department. There's a growing movement. A lot of these papers are surprisingly old, and yet the embrace has been relatively slow. So number 2, only 18 patients, but it's back from 2002, accelerated ED pathway. This was a much more conservative pathway, and the only reason I wanted to talk about this one is because it had some elements that are kind of maybe controversial. So they randomized them to be treated in the ER as an inpatient. They gave them low molecular weight heparin, which seems to make sense. You just get a shot of this in your belly kind of thing, and it lasts for a day. And the idea is if you convert sometime, you're at risk even if you spontaneously convert or throwing something, no less if they jab you. So the idea of having 1 shot of heparin on board does seem to make a lot of sense. And I'm going to ask you when we're done here, what is your protocol? But that's what they do here. And the other thing is they also, what they did selective transesophageal echocardiogram. Now, I want no parts of that. You swallow this, this thing here, and to see whether you have any clots in your atrium, primarily you're looking for left atrial appendage. And I decided to get a runny nose just now. You're very kind. Thank you very much. You're very kind. Yeah, Annie, thank you very much. Thank you. So that's what they did, which is kind of unique. And they're looking for basically to see if you got any clots in your left atrium. Mean time to conversion is 5 hours. 5 hours versus 30 hours when they admitted them to the hospital. No complications on 27-day follow-up. Length of stay 1 day versus 2 days, and it was cheaper. But look at these costs. These direct costs, like our CBC costs more than these things here. 3 is a Canadian study. Again, it's 10 years old. 289 people. That's a lot. New-onset AFib. Again, they had the 48-hour cutoff. Spontaneous conversion, 15%. When you look at these papers, they all talk about the variation in spontaneous conversion. Some of them are like 5 or 10%, and the others are 60 and 70%. Well, how do you get such wide variety? You need to look at how quickly, they're looking at spontaneous conversion within 4 hours, 6 hours, 12 hours. Well, obviously, the further out you go, the number is going to get higher. So sometimes they compare our technique with what happens spontaneously. And if you convert somebody within 4 hours, the majority of other patients are not going to convert on their own within that period of time. So these guys use chemical cardioversion in this one with IV procainamide, which is probably, I don't think probably, if you look at the drugs, it would not be on your top of your list, but anyway, that's what they did. And they attempted this conversion in 60% of the people and were successful in half of those, which reflects that procainamide is not maybe as good as some of these other drugs. Electrical cardioversion was done in a bunch. 93% of the electrical cardioversions were done by ER docs. 97% were discharged from the ED. Wow, that's pretty good, similar to the other paper. 1 thromboembolic complication. Now that's 1 out of 289. 1 out of 289. They don't say anything about whether they got their Lovenox shot. I don't even know if Lovenox is around in 1999. 4 is a study from Diane's Hospital, Harbor, UCLA. Retrospective look, 229, so it's pretty good. 94% of them were admitted following the U.S. tradition. Everybody get in you go. And they looked at the charts and said, retrospectively, we calculated and concluded that a third of these people did not need to be admitted. And frankly, that's probably probably even more than that. 5 is too old. 6 is 1986. This is not from Canada, it's from Cornell. The other authors say, we're questioning the need to admit all new-onset atrial fibrillation and concluded that patients needing admission will have other things that are manifested in the emergency department. All right, so that says do it in the ER. Should we attempt to convert new-onset AFib to normal sinus rhythm? And the answer is yes, if they qualify. Now, some of the studies talk about the spontaneous conversion rate of 75% or something like that. But you have to say, how long did it take them to get that? And do you want to just hang around waiting for it? Maybe it'll convert. It might be a day, and it might be a day and a half. They're going to convert. Or do you want to do something more proactively, knowing that you got this clot issue to deal with? You've got the idea that these people will more likely convert if you do it sooner rather than later, and the clock's running. So number 7 reaffirms 114 hospitalized AFib patients. Spontaneous conversion occurred in 50%, but 89% if you were only within 48 hours of the onset of this thing. So spontaneous conversion is the rule if you give them enough time. This paper I think is a little atypical. Early spontaneous conversion was common within 1 hour of arrival and a quarter. Within 1 hour of arrival, you can't even get registered in our hospital in an hour. Next issue is the anticoagulation issue. It's unclear in short duration AFib whether this needs to be done or not. If it does, the benefit has to be very, very, very small. You saw one study, 289 patients, 1 thromboembolic event. So number 8 is a large study, 375 folks with AFib less than 48 hours. It's from Harvard and University of Connecticut. It's a 12-year-old paper. Spontaneous conversion occurred during their hospitalization in 2/3 of the cases, but the mean interval to conversion was 1.7 days. That's the hooker. Yeah, you look at these numbers, yeah, a lot of them converted. Well, you want to wait 1.7 days, then you get into the coagulation. You got to be in the hospital. This is not good. After presentation, they came to the ER. 1/3 of them got IV heparin. Now we don't have to do that. 18% got aspirin and 7% got warfarin. And 3 patients had a clinical thromboembolic event. All of them converted spontaneously. So that it doesn't matter whether you induce it or they convert spontaneously, the risk is still there. Now what I don't know, frankly, is whether the risk is greater if you shock somebody. If you shock them, you're going to cause this massive contraction of the heart one time. And is that going to eject out of the left atrium, this big goomba, which is going to go down to your pulmonary artery kind of thing? Is that going to be different than just you just convert spontaneously? It would logically appear that way, but I've never seen anybody say that. And it's obviously going to be very difficult to study that when the incidence of thromboembolic complications is so low to begin with. And I think more and more people are giving a shot of low molecular weight heparin as part of this protocol. There was no significant difference in these clots. There's only 3 of them, whether you were anticoagulated or not. So these papers support early cardioversion. They advise initial use of IV heparin on admission and continuing for 24 hours. That's that business about the stunned atrium still at some risk after converting. But 1 shot of Lovenox will take care of that. 9 indicates the risk of clots is significant with AFib lasting more than 48 hours. So here's a study where they did the TEEs, found atrial clots in 13% of almost 700 patients who had average 4.5 weeks of this. 1 out of 8 had an atrial clot when they did the transesophageal job, which is pretty high. It's interesting that when they did not find the clot in this, they didn't anticoagulate them, and they cardioverted them, and none of them had a clot. So, if you really want to know the answer of you need to be anticoagulated, this says clot, yes you do, no clot, no you don't. None of them developed any embolic complication if they converted them and they didn't find a clot on TEE. So that's kind of one of the really conservative view that says, let's do this before we make any conversion. But the fact of the matter is if you're within this 48-hour window, the likelihood of you getting any kind of trouble is so small. But that's addressed in number 10. Where's the literature that supports this 48-hour cutoff? Looking for hard evidence regarding the time beyond which anticoagulation is needed, and concludes there is no evidence. So says a review of 54 papers that concludes that none answered the question. The 48-hour limit is not defended by the literature or supported, nor is the concept of anticoagulation after cardioversion, this idea of the stunned atrium kind of thing. All right, some of the drugs. Propafenone. Propafenone is an Italian drug, propafenone. 11, 12, 13, and 15 talk about propafenone. 14 got misplaced in there. It's about procainamide. All of these papers on these drugs say the sooner the better in terms of its working. They all basically say, most of them are IV or oral, where they work similarly effective. It takes a little longer oral. And they talk about their IV protocol and their oral protocols. But look at this, in this paper, the summary here said, IV dose with a bolus in the beginning, followed by a second bolus after 10 minutes, converted the majority of patients to which it was given within 30 minutes. So this is basically aggressive chemical cardioversion. Within 30 minutes, the majority of the cases. When they orally loaded these cases, the majority converted within 4 hours. You're supposed to avoid this in CHF. Conversion rates exceeded, their conversion rates exceeded the spontaneous conversion rates by 20 to 30% at least. Sustained atrial flutter is one of the concerns in giving these people these medicines. Because if you get a 1-to-1 atrial flutter, you went from the frying pan into the fire in these cases. And this occurred in 6% of the cases, but it was similar frequency when you look at these studies, whether it was a control case or actively treated case. So you can't blame the problem because you gave the medications. And some people therefore say that before these medications should be given, you should block the AV node. Well, you already did block the AV node because you slowed the rate down by giving them some calcium channel blocker. So that this should not be really a big deal. Now, there's a listing of some other adverse effects. This is not, super dangerous, but there are some issues. Ventricular pauses of greater than 2 seconds, QRS complex widening, hypotension, bradycardia. There are these drugs which slow your heart and convert your heart, and there's other drugs that convert your heart but don't slow it. The list of drugs that slow your heart and convert your heart: magnesium, we talked about magnesium, that's for sure. Amiodarone, propafenone, and clonidine are the 4 drugs that will slow it and convert it more than just giving a calcium channel blocker, which is just going to slow it. IV and oral amiodarone. This is the drug that is probably the safest drug to use in these cases. Maybe it doesn't work as quickly. It's a drug of choice to use in people who have some failure or having some cardiovascular instability, and but you still don't want to shock them, kind of thing. IV and oral routes are both effective. There is this idea of loading followed by maintenance doses. There is some controversy about people who have AFib in the setting of WPW, whether this drug should be used. Some people say yes, some people say no. There's a paper in there by Mel Herbert that says no. So that's number 2 drug. Let's go back to 14. This is the procainamide paper. This is by Ian Steele, the Anticoagulation doctor, the Opals doctor, probably the most famous researcher in all of Canada. Retrospective using procaine in 341 adults with initial AFib or flutter. Then they discharged them from the ER on no meds, which is a little bit of controversy. We'll talk about that, what they ought to go out on. And they converted a lot of these people, and they had adverse events in 10%. 10%, not a big deal. Hypotension, usually transient, was in the majority. Well, we're used to dealing with hypotension in the setting of dealing with AFib because a lot of the drugs, the calcium channel blockers that we give these people often result in them being a little on the hypotensive side. The average length of stay was 4.4 hours in the ER. They didn't mess around. Bam, in, out, goodbye, next, kind of thing. So that is probably the shortest that I've seen. Now, what about a comparison? 20 is a comparison. Amiodarone, propafenone, and procainamide, and placebo. 362 adults, Greek study, AFib less than 48 hours, an extensive exclusion list, randomized to see one of the 3 drugs or placebo, and the rates of conversion: procainamide 68%, the average time was 9 hours, median 3. Propafenone, 80% conversion, average time 8 hours, median 1. Much faster, much faster. And then there was amiodarone, 89% conversion rate, average time 12 hours, median 9. So slower for sure. Amiodarone slower for sure, but better results. What about placebo? Now, in this study, 60% converted with placebo. So 60 versus 68% with procainamide. That's an 8% difference. Number needed to treat is 12. 12 people had to be completed with procainamide to get one with an advantage of being converted, comparing nature taking care of it. Propafenone 80, amiodarone 89%. So there's like a 28% difference with amiodarone. Number needed to treat something like 1 in 4 to get benefit. Amiodarone and propafenone were statistically superior to procainamide. No proarrhythmic effects occurred in the study. They also talk about ibutylide, IV ibutylide. This is like a liquid electric shock. Mean time to conversion, 27 minutes using their IV protocol. We don't get into the specifics. Conversion rate, now here's a great example. Conversion rate was 44 to 49% versus 2% spontaneous. 2% spontaneous over what time period? Well, these guys are converting them in 20 minutes. Predictors of conversion, AFib less than a week, and normal size atria. Big atria problem. Polymorphic V-tach in 8%. It's 1 in 12. That's a little frightening kind of thing, 1 in 12. What about oral clonidine? Clonidine is like a sympathetic, shuts off the sympathetic. You know, it just pisses you like a frog. And number 22, Israeli study, only 18 patients. Oral dose was repeated. Look at this, they gave one little pill. You know, that clonidine is like 0.1 milligram. You just like lick the tablet, it's so powerful kind of thing. Oral dose, 0.75 milligrams, so it's one tablet. 4-hour study. Mean heart rate went from 132 to 82. So this really puts the brakes on. Sinus rhythm restoration, 6 of 9 versus 1 of 9 in the controls. So you don't hear anybody using this. Anybody got any experience with clonidine? And then there's the 23 through 25 is on the flecainide, which is another one of these liquid electric shocks. Conversion was fast, 14 minutes IV, an hour and a half PO. Early treatment, less than 24 hours, facilitated conversion, over and over and over again. May cause hypotension. There are some other things that are much more effective than procainamide. And last cluster of papers is about defibrillation. So 26 says, not defibrillation, cardioversion. 26 says we like propofol better than the midazolam. How many of you are not allowed to use propofol in your emergency department? We're friends. You can tell me. You know, we're not. I mean, our anesthesia. His quote was, "I think it was over my dead body." I think that was what the phrase was. You know, and at the time, it wasn't politically appropriate to go take this guy down. 27 and 28 about ED cardioversion are all these success stories within 48 hours, high rates of conversion. Complications, most complications relate to sedation, not to the shock. And these guys, 22 to 28 complications because of you sedating them. Majority were discharged from the ER. ER stays were short, 4 hours. Again, very, very short, very short. No thromboembolic events on telephone follow-up of 30 patients. Well, you know, you can't say anything about that. And lastly, this pill in the pocket. Everybody here pill in the pocket. So you have recurring spells of atrial fibrillation, and you don't have ischemic heart disease. You've been excluded from having that, and you don't have any underlying nasty problems. And so they give you either a butylide or propafenone, and as soon as you get this, you take these pill in the pocket, and it kind of converts you in the majority of the cases. And this was a New England Journal paper that talks about it. Now, that's obviously not going to be something that you're going to be doing, but there are people. Anybody know of any people carry around a little propafenone in their pocket?
It wasn't propafenone, but I've had patients that whatever pill they had.
Because this can be a hassle. You're on a 5-hour flight to Hawaii, and 1 hour out, you start fibrillating. You know, what are you going to? Fibrillating for people can cause problems really, really short time in terms of shortness of breath and those kinds of things. So this is about giving these people this treatment. Not everybody will qualify. It's not done. very casually, but that's what it's about. The rest of this is on AFib, where we don't know when it began. So those people that's the standard case. They get rates slowed down, they get anticoagulated. Some of them, depending on their aggressiveness. This chart, I think, is from the Heart Association. I borrowed this chart from them, and it goes through some of the doses and the pros and cons. But the part that is kind of interesting is this one here on the bottom. You can't read very well. When you steal stuff, you can't ask that it be high quality in terms of I kept on coming out fuzzy. But this basically shows that the drugs that are used to maintain sinus rhythm after you have been converted really depend on what is your underlying cardiac process. And if you have ischemic heart disease or CHF, then the drug that you may be on is going to be more likely amiodarone. It is, when you look at these, amiodarone shows up the most in terms of these treatment algorithms. So now I have to ask you, what drug do you use for chemically cardioverting these patients? Your experience? Electricity. No? Okay. No drugs? Procainamide? Anybody? Come on, the Canadians, you could tell us. Amiodarone? Magnesium first? That's terrific. There you go. Anybody else? Flecainide. Are you from Australia? Nobody's using infusion of amiodarone? Ibutylide first. Anybody back there? Amiodarone. You're the only guy in the audience. The nice thing about amiodarone is it's the safest. May take a little bit longer, but it'll also slow the heart rate down so that this stuff can be given. Usually after you have AFib come in, you give this calcium channel blocker, and within a half an hour, the rate is down to something that is acceptable. Then you start this amiodarone infusion after giving a loading dose, and you just watch for a while. The question is, how many of you give an injection or low molecular weight heparin in this environment? Sounds like it's a reasonable idea. And how many then would go out on anything? The idea of sending somebody out on nothing sounds a little strange to me. Something caused this to occur. We're not quite sure what it was, but we like to prevent it from going again. You're going to get followed up by a cardiologist, but it's perfectly reasonable to send people out on the safest of the bunch, which is probably amiodarone. So the idea of taking 600 milligrams of amiodarone for 1 week, and then down to 200 milligrams, it's a 200 milligram pill. Thereafter, for a little bit, it's not going to cause you to turn blue, pulmonary all that stuff, fibrosis. You're taking one 200 milligram tablet after you've loaded yourself for a bit to avert this coming back while they find out more about you. Well, I think that in terms of aggravating it or causing it, we're not talking about giving this stuff indefinitely. We're just having you leave the building on something that will likely decrease the recurrence rate of this problem. Pardon me? Is that how long it takes to get a problem? Well, that's not very long, but I don't think that your job, I think, is a week or two kind of thing. Are you going to get followed up by a cardiologist in 3 or 4 days? Yes, I am, kind of thing. And I think even cardiologists may put you on a little maintenance dose just for a while till I feel comfortable.
Are there any studies about the one shot of low molecular weight heparin?
No.
The other kind of one shot anticoagulation.
No, the data on this is really bad.
On one hand, it does sort of make sense, but on the other hand, you've got a clot floating around there already. Is one shot really going to keep it from rotting?
Well, no, statistically, you don't have a clot. If you have this less than 48 hours, these are like 1 out of 300 had a thromboembolic complication. The numbers are certainly less than 1%, certainly less. So this is kind of like a little prophylactic kind of thing. It makes some sense, but there's no data to support it. Any of you give a shot of heparin or low molecular weight heparin in this process? They get a little low molecular weight heparin. Lasts a day, that's good. So I guess the idea is for you to feel more comfortable suggesting that this is something that you ought to talk to your cardiologist about and gradually move into this, because the literature is very, very supportive of it, but it has not been widely embraced.
I guess one of the questions that's kind of begged by all this is how good are patients at telling us when their atrial fibrillation?
How good are patients? Some of them
And are they
can
better,
tell you to the minute when it was started.
or are they telling us when it became rapid?
I think it's rapid like that. As soon as it begins, it's like 130, 120, you know it. And yeah, if the person doesn't, is a kind of, they're clueless, well then they go into the other pathway of the undetermined. But I can tell you that many, many people, I think the vast majority, can tell you to the minute when this goes, or certainly within the hour when it happened. We just had a lady, a great case, 66-year-old woman came in, and she thought she was anxious. You know, and she was new-onset atrial fibrillation. She could tell you when this anxiety, she wanted, you know, some anxiety pills, but she didn't get any of those because that wasn't her problem. But so this palpitation was interpreted as a reflection of maybe anxiety, when in fact she was an uncontrolled atrial fibrillation, never had it before.